Hello, everyone, and welcome to today's webinar, Navigating the Cures Act and What Every Behavioral Health Provider Needs to Know About Sharing Notes with Patients. So, I am so glad you were here. And so, just thank you so much for joining. Can everybody hear me okay? Am I loud and clear? I was having a little problems with my mic before, but can you hear me okay? Yes. All right. Thank you, Angela. Great. All right. Fantastic. I'd love to see where folks are from today. If you don't mind sharing in the chat, if you don't mind putting your discipline in and then where you're from, if you mind sharing. Thank you, Lori. Thank you. Thank you. Thank you guys so much. I appreciate you. Thank you. Excellent. The important thing and why I was asking for disciplines, because it really doesn't matter whether you're a clinician, you're an administrator, you could be a compliance leader. I see some folks in here from that field too. So it's good to see you. This topic really affects all of us working in behavioral health. And with the implementation of the 21st Century Cures Act, patients and clients now have a greater access to their clinical notes than ever before, right? Ever before in history. And so that shift brings a lot of opportunities, but it also brings a lot of challenges. And so we're going to break it down today, like what the Cures Act and information blocking actually requires, like how this impacts behavioral health documentation. Specifically, we're going to be delving into behavioral health. And so some real world examples of what to do. And basically also how we can align compliance with compassionate, high quality care. And we're going to have time for Q&A. So do not worry about that. This is absolutely going to be recorded. So you will get this recording. And we also have handouts. And I'm happy to answer your questions in as well as we go through this. And what I'll say, and thank you guys so much for being here. We get folks from everywhere and all kinds of disciplines. So it is great to have you here. I'm seeing like Kansas, Mississippi, Atlanta, we're neighbors, Georgia, I'm in North Carolina, Arizona, New Mexico, New Jersey, California, New Hampshire, Wyoming, Wisconsin. Great to have you guys here. Excellent to have Tennessee, also neighbors, South Dakota, lots of Arizona. Great to have you guys here. Compliance security, love it. North Carolina, Julie, we are sitting in the same state. I am in Charlotte, born and raised in North Carolina, but also Pittsburgh. I was raised some in Pittsburgh, so great to have Pennsylvania here, Baltimore. That's where ICANotes is located at. So fantastic to have you guys here today. Thank you so much. Thank you. Thank you. Excellent. All right. We're going to talk about the First Century Cures Act and really delve down into it. Now, just out of curiosity, because I like to know where people are at, tell me about how much you know about the act. Do you feel pretty good about it? Do you know about it? Are you just learning about it? And I'm going to tell you the ways you have to communicate with me. Someone just in the private message, which is perfect. You can private message me, especially if you have a question and you don't want everyone to see it. You just put it in the private message to me. Okay. You could also use the public chat, which is what a lot of you are doing right now. That's absolutely fantastic as well. And then we have Q&As listed there, but I'll be really honest with you. I see those last. Like they're hard for me to get to in this particular webinar platform. So use the public chat, use the private chat. I'm absolutely here for it. Someone has said, yep, I don't know anything about it. Nothing. And that's okay. You're here today and you're going to learn a lot about it. So 0. I like that, for instance. 0. Not a problem. You're here. Not a big deal. We are going to take care of you today. By the time you leave this, you will know all about it. You'll probably know some things you do not want to know about it. And that's okay. That is okay. And especially, we've got Pamela said you want to teach nursing students. Fantastic. All right. Let's just absolutely dive into it then. I talk a lot about what's on the slides, but I don't really go always by my slides. Let's just do a little recap. The Cures Act is like it's a big bill, had a lot of great things in it. Like brain mapping was in it, money for cancer, like all kinds of great things were in this 21st Century Cures Act. And it was a federal mandate. It just pushed for transparency and healthcare records. And the part of that was information blocking. And really what it did was aim to prevent this unnecessary information blocking that's been going on in healthcare for a while, because there were organizations that did that. And if you've been in healthcare for a long time, I have been in healthcare and been licensed since 2000. I feel old when I say that, but that's okay. So that's 25 years. But look, and I worked for hospital systems that would charge people for their records and charge them per page and make it really hard for people to get their records, right? And a lot of times they did that because they didn't want to be sued. And sometimes they did it because they just didn't want to deal for the hassle of people looking at their records. But that's why this rule came about. But the problem with it is it has major implication for how we document and share clinical notes with patients, especially in behavioral health. Now, this is an old law. Like it was enacted in 2016, but like a lot of things in government, it takes a long time. It was till 2021 when the final rule was actually enforceable. And again, it's all about preventing information blocking. And it also came from a study who found that more than 7 out of 10 patients who access notes felt more in control of their health. They did it. And this was a generalized study on all medical notes. And we'll talk about that a little bit later because I'm going to tell you how to stay compliant with this rule. But I also have really strong feelings about the rule as well because it's behavioral health. So it's a little bit different. And I will tell you, if you're like, look, I don't want to share my notes with my patients and clients, you are not alone. They did an actual survey that 38% of behavioral health providers expressed concern that transparency could impact rapport with their patients and it could actually affect therapeutic outcomes. So that is something that if you're feeling that, you're not alone. The studies back that up. And so there's a lot going on with that. But the problem with mental health and the implications for that right now is clinical notes should be available for clients. And that includes the diagnosis, the risk assessments. And in that can also, and a note could include a trauma history. There are a lot of things going on with that. So that's why we want to talk about that in depth because notes that were previously considered like clinical eyes only. You didn't share your notes, right? They're now required by law, some of them to be viewable by patients. And so that really strikes a balance between here, we want transparency, right? We want transparency, but we also want patients and clients to have emotional safety and they can misinterpret things. If you say something like guarded, what does that mean to certain people? Non-compliant. People are often non-compliant with their medication regimens, but that someone might take that as it might hurt someone's feelings. And it can really undermine the trust because if the client feels like you're talking about me or I feel like talked about rather than talked with, that's a very real thing too. So now there are the ways that you can use exclusions for this. You have to do it judiciously though. And there's like a preventing harm exception, there's a privacy exception, there's an infeasible exception. So we're going to talk about those exceptions as well. All right. Again, with information blocking, it is just defined as any practice that's likely to interfere with access or exchange of EHI, which is electronic health information. And I will be honest with you, if 80% of clinicians were found to be unclear on what constitutes information blocking, so if you're like, I don't know what that is, then that's okay. You're with the 80%. Okay. But here's the problem. Just in 2023 alone, there were over 500 complaints related to information blocking that were filed with the Office of the National Coordinator. And the problem with the information blocking is the ONC and the Office of the Inspector General announced that there are penalties that could reach up to $1 million per violation. And that could be for health IT developers or networks. And so that's a big fee. And do you remember back, if you're like, we have some folks that might remember when HIPAA came out and they started talking about fees and they didn't do anything about them for the first couple of years. Like they didn't roll in heavy with fees. And then people started getting fees and like jail time. And it became a big deal. That is where information is going, unfortunately. And so we're actually headed in that direction where clinicians may face investigations and reputational harm in financial penalties if they're not directly levied. And they're talking about doing that in the latter part of this year. So that's really scary. And that's why I was like, we need to talk about this more. Also, some things changed. Some of the exceptions that they had changed. And I was like, okay, we definitely need to talk about that. So now, as far as folks that must comply, healthcare providers must comply. Health IT developers that use certified ONC programs must comply. health information exchange networks. Like if you have a health information exchange, like North Carolina, the health information exchange is required for Medicaid. It's not an option. That's the only state that is absolutely required for everybody that uses it. There are other states like Arizona that has it for inpatient facilities, but that they must all comply with that information blocking. And let me give you just quick real world examples. We'll definitely dive in later on. But if you delay patient access to therapy notes because you need to review them or create them in some cases, if you if you require patients to submit paper forms for like electronic records, that can be considered information blocking. There's these little caveats that people are like, I had no idea. And so I want people to be in the know so you're not like caught off guard. Also, if you omit progress notes from shared records and you don't give a valid exception, that would be why. That would be one of those kind of real world examples of information blocking. I'm getting another question here. It's great. I love questions. If I delay releasing a note because I'm concerned a patient may misunderstand or become upset by the content, does that count as information blocking? Yes. Yes. So they asked if I delay a note, if I delay releasing a note because I'm concerned the patient may misunderstand or become upset by the content, does that count as information blocking? Yes. In most cases, that would be considered information blocking. Unless there was a specific exception, like the preventing harm exception, which I'll go into a little bit more. But under the Cures Act, discomfort, confusion, emotional upset aren't valid reasons to withhold access. All right. That's the only time the preventing harm exception applies. And I have a whole slide on this, so we'll go over it in depth and you guys will know it by the end. Is when disclosing information is reasonably likely to endanger their life. All right. Or physical safety of some kind. And we could talk about some examples of that. If you're concerned about that, I want to answer the question now, though. I would have a conversation with them beforehand. I'd walk through sensitive content with them. I would use plain language and respectful language in that documentation and things like that. Listen, the rule encourages us to document with transparency. It does not encourage you or force you to hide or soften the truth, but it just to create a record that the patient can engage with meaningfully and safely. Let's talk about some key deadlines because we're really going to get in the meat of it. Key deadlines here, they're listed up on the screen for you as far as October 22nd and then 2025. The main thing we need to know is that these compliance reviews are increasing. I'll be honest with you guys, when this law came about, I thought this is going to be hard to enforce. It would be hard to report. They didn't have reporting set up for it. So I was like, who are they going to report to? No, they did that. They set up reporting. One of the scary things, though, is you can actually go and look to see who's reporting these incidences. And the first year, 30% of them that were reporting were lawyers. So then that I was like, oh, that's not good. That's not good because that means they've jumped on the bandwagon of information blocking. So that could be very problematic. So yeah, just to give you some details on that, these are the absolute dates for that. Now, other things that we need to know is that somebody said, what's delayed access to notes? That is if a scenario of a behavioral health provider like routinely delayed sharing psychotherapy progress notes, let's say for 5 to 7 days, because they wanted to review them first before patients could access them via the portal. And the outcome is you can be flagged for potential information blocking, right? Reviewing notes before releasing them isn't a valid exception. I know what you're asking, but that's not a valid exception unless it's a documented immediate risk of harm. So the takeaway from that, I guess, is you can't create delays as like a default practice. Delays have got to be justified by a case on case basis. Now, what I will say to you is you can absolutely call your client, and we'll get into this a little bit more. You can call your client if they ask for their notes and you like don't feel like they're ready to hear them and say, hey, can we meet? Can we go over these together? Can we go over these together so I can explain this to you instead of them just reading them? Absolutely. Absolutely. I got a really long question. I'm not going to say it takes a law supersedes ethics, right? B6E, client access counselors provide reasonable. So does the law, I'm just going to say he said a very long thing, so I can't read this all. Really well written, but does the law now supersede ethics? When you're talking about B6E, the ACA Code of Ethics, can we limit access to records if there's compelling evidence of harm? The Cures Act seems to require sharing almost everything. So which takes priority? I hear what you're saying. This is where law and ethics intersect, right? But the law takes legal precedence. And this you've got a really good point. If you want to put it in public chat, you feel free, but private chat, I get it. The Cures Act is a federal mandate, though. Okay, and so under the information blocking rule, providers have to give access to electronic information, and unless those narrow exception applies. So yes, unfortunately, this is awful, but the law supersedes the broad ethical discretion. And I see what you with the ACA guideline B6E. It allows, it aligns with the spirit of preventing harm. So if there is evidence of serious harm, you can withhold it. But under the Cures Act, it's got to be serious, imminent, and very specific. And you've got to document that rationale so clearly that there cannot be any vague discomfort or general concern, right? And you can only withhold what's necessary. And I hear what you're saying. I get it. And ethics helps shape how we apply the law, right? But the Cures Act sets the minimum legal standard. And so not complying can result in being investigated for information blocking. Really thoughtful. Michael, you posted it in there. I wasn't going to say your name, so you posted it in the public. So really thoughtful question. Agree with you. This is definitely where laws and ethics intersect. So great thing there. Absolutely. All right. I'm just going to say a couple other things. EHR vendor blocking, we can't do that. And ICANotes, now some EHRs will just go ahead, you write a note and they'll release it. I have a lot of my friends that are providers with a very large hospital system. They use a large EMR. And that EMR is, we're not getting in any trouble for information blocking. You write a note, we're releasing it. That's it. And they can click an exception, but it just happens. And so ICANotes is a little bit different where we hold the note, and when they request the note, then they get the note. So we're a little bit different like that. And we're going to have a demonstration on that a little bit later. But paper record, only records access. So if a healthcare organization only allowed patients to request and receive like records in person or by mail, even though the EHR supported digital sharing, is that what you're saying? The patients can file complaints, and there was an exception like that happened where the healthcare organization, they said, look, you got to submit this in person or by mail. But the EMR itself supported digital sharing, and that patient filed a complaint, and the ONC actually ruled that was information blocking because electronic information must be provided electronically if it exists. Now, the takeaway, if it's digital, you have to share it digital. You can't like force patients to jump through outdated hoops. I hope that helps. What about okay, yep, you got a good question. Can you still hear me? Thomas said I lost audio. Can you guys still hear me? You can just hit yes in the chat. Yep, thank you, Angela. All right. Somebody said I only use paper charts. Okay, so what about providers who only use paper records? Are they subject to cures and information blocking? Yes, but there's some key differences, okay? The cures information blocking applies to electronic health information. So if you only use paper records and you don't have any kind of certified health EHR, you're not subject to information blocking around the electronic health information, but HIPAA still applies. So under HIPAA, patients have access to their complete medical records, and you've got to get it to them within 30 days. But here's the caveat. If you scan or store any part of the record electronically, that portion does fall under the Cures Act, and you may be required to show it without unreasonable delay. If you're just completely charting on paper, sure, you got to get it to them still. But if you put any part of that and you store it electronically. So the bottom line is all providers have to honor patient access or HIPAA. But if you don't use an EHR, you're not bound to the Cures Act real-time EHI sharing rule, but you still are expected to provide it into a reasonably timely manner. I hope that answered the question. Did that? Absolutely. Yes. So let me know if that didn't answer the question. I hadn't heard that one before, so I appreciate it. I'm learning things, but that is the one. Like another thing is blocking adolescent records without clarifying consent rules. Someone asked about that. Like if there was a scenario where a pediatric office refused to share any information in the portal for patients over the age of 12, and they cited privacy concerns. But the outcome was there was an investigated a blanket policy that didn't reflect the nuanced state consent laws or individual parents' rights. So blanket exclusions are not always compliant. You've got to assess and apply state-specific privacy and consent laws appropriately. It is a twisted web. It is a twisted web, right? But people are making these complaints they're making the complaints and it's public and the OIG is investigating them and it's finalizing these penalty structures for providers now. Got another audience question. Can we delay psychotherapy notes for a few days to review them? I think I already went over that. No, unless there's a documented immediate risk of harm. So what if we haven't done them? Great question. If you haven't done your notes, do them fast. Make it a priority. Make it a priority. Absolutely. Yes. All right. Perfect. Let's move on. Let's get into this because the next slide is going over notes that must be shared. So these are some of the notes that absolutely must be shared. Progress notes, psychotherapy notes with exceptions. Psychotherapy notes with exceptions is something that must be, that's one thing that there are exceptions there. Discharge summary, medication, and treatment plans. Treatment plans. And a lot of people say, I don't necessarily want to share psychotherapy notes. There are definitely some exceptions to that, and we will talk about that as well. Let's see, 30 days for handwritten notes. Yes. Let's go over to the exceptions of sharing. And these are some of these, and I just want you to take these in for a minute. These are some of the exceptions to information sharing. I'm going to get this next question. Shanda said, how do we know if there's potential harm if we cannot review the notes for potential harm? You can. You absolutely. So let's talk about that preventing. Let's go in depth on that. All right. So preventing harm it's got to be individualized. It's got to be supported by clinical judgment and it's got to be limited to a substantial risk of physical harm. All right. Now, when open notes first came out, they were really unclear on the term harm. So a lot of people were saying, like, if it hurts their feelings, that could be harming my client relationship. And nobody had a really clear understanding of that. And now they've come back and they said, look, it cannot be used for avoiding emotional discomfort. Only true safety risk qualifies for that. Only true safety risk. And listen, I take that a couple different ways, and we can talk about that now. I'll give you one just off the top of my head. Let's say that you're dealing with a client who's in a domestic violence situation. Maybe they have a boyfriend in the home or a husband who is, or wife, doesn't matter, in the home who gets all of their text messages, reads all of them, has access to their email. And during the sessions, you're talking about the abuse that they're suffering, how they want to leave the situation, but they're scared for their life. And that point, if you think, you know what, this person could go in and ask for their records, and it might not be my client. It might be their abusive spouse. And if I post these to the portal, my client's abusive spouse could have access and they have access to their email, their passwords. They could probably get on the portal and look at the notes, and then that could get them killed. And that's a real scenario, right? I think we can agree with that. That's a real scenario. Unfortunately, probably some of you are working with clients in that scenario right now. That is a preventing harm exception. And you can attest and speak to that. So if they wanted to see their notes, you could say, you know what? Why don't we come to my office? I could share the notes. Absolutely. Absolutely. And so that's another thing. Michael says, I have a client who has serious SI multiple tips. Reading some of their notes could be a risk factor. Would that be an example of imminent risk? Yes. Yes. And I'll talk about that a little bit later. But yes, absolutely, that could be. It really can. Matter of fact, that's my next slide on documenting the harm exceptions. And I'll get into that more. Absolutely. Let's talk about privacy really quick. There are 4 sub exceptions with legal preconditions, HIPAA-based denials, patients withholding requests. So if a patient requests non-disclosure, you're protected. If a patient, I don't want to know, I don't want to see my notes, and I don't want you to give them to anybody, you're okay. You're okay. So that's one thing. Security exception, that's like about protecting data. Health IT exception, if you have an EHR, you cannot claim that one. You can if you have notes, paper notes. So there we go. And the also health IT is that's more in feasibility, but health IT is if the system was down, if there's a temporary shutdown or they were doing system maintenance or something like that. If there was infeasibility is if there are uncontrollable events or undue burden, you have to require an explanation of that within 10 days. But there are things based on that. Absolutely. And another thing that one thing that I want to be very clear of is, and a lot of you said, I don't know anything about information blocking. One thing that I want to be very clear on is you cannot charge your patients for their information anymore. You cannot charge them for their information anymore. And I know that people used to do that all the time. All the time. We were helping folks set up billing, and ICANotes would have a charge for their medical records. I hear it. It was there. It's very prominent. You cannot do that. If you take anything away from this webinar and you're charging, do not charge. That will get you in trouble the absolute quickest. They have access to their healthcare information for free. For free. Absolutely. They're very focused right now on charging for data because they think it should be free. And I agree with that, to be honest with you. There are some things that I absolutely agree with. Okay, so I'm going to go on to the next slide. Whoops, where is my other slide? Hold on just a moment. Ooh, Angela, I'm gonna have to back. Here we go. We're gonna do this slide and then we're gonna head back because I moved them. This is on how to document harm exception. It must be serious, what Michael said. It must be imminent harm, right? And it must be specific to the patient. And this is as of 2024, fewer than 15% of information blocking complaints submitted to ONC involve properly documented harm exceptions. Most were rejected. They just didn't meet the imminent serious harm part, right? And I think, honestly, when we talk about this, the preventing harm exception is probably one of the most misunderstood areas of the Cures Compliance Act, especially in behavioral health area. So, again, this is not for emotional discomfort. It's not for you feel they may get confused, you worry the patient may disagree with what you wrote. This exception, there's got to be serious imminent risk of physical harm. And it's got to be specific to that patient and you've got to document it clearly. Now, if you have a case of someone who's acutely suicidal where reviewing the note could escalate that risk, that exception may be appropriate. But you need to back that with real concrete clinical observations, not just your intuition. You've got to be able to write it down with clinical observations. And it is a very narrow case by case exception. And it's not a policy you can just apply globally and be like, most of my patients are suicidal. So, I just don't share notes. No, that could land you, if you do that improperly, that could land you on the wrong side of an ONC investigation. You do not want to be there. Again, only for emotional distress, preventing harm. Only for physical safety, not emotional distress. And it's not applicable for minors confidentiality when you're blocking parents with lawful authority. All right. And any use of the exception requires, again, a really strict adherence. Questions here. What if it triggers my client within the note? No, you can't block it. It triggers your client. If it triggers your client, maybe commit suicide, but emotionally trigger, no. Listen, I don't like it either. Okay. I'm going to be really honest with you. How many of you, I don't know a good way to ask this question, but probably a lot of you don't like this, right? Is what I'm hearing. And I don't know if we have the emoji set up. I don't think we do on this one. I was like, you can give me a thumbs up or a thumbs down, but I don't think the emojis are set up this time. But basically, a lot of people don't really like this, especially behavioral health, but clinicians. And I'll be honest with you, I don't really like it either. It's a law. There's nothing I can do about it. I love research. I will tell you that's one thing I love. Other people, they go to bed, they read a nice book, or they watch a TV show. I get into research studies. That's what I love. And I will tell you, there was no good research done on how this would affect mental health clients. All right. The closest I saw this before this was released, open notes, was pediatric oncology patients. And that is not, and they actually tried to justify that. We released this for pediatric oncology patients and it's actually going well. And I was like, that is not the same as mental health. That is not. So prior to mandating all of this, they did it for all healthcare notes. There was not adequate research done on how this would affect mental health clients. And I think they missed the mark when they said it had to be for mental health notes. So, yeah. And that is just one of the things that is just really, I don't think they did a good job with. And then I will get off my soapbox now. I'm going to start answering questions again. I got another question. If the patient is actively suicidal, can I use the preventing harm session? Yes. Yes. If you clearly document that releasing a note is reasonably likely to cause physical harm, I would document that within a private note section. We have that in ICANotes. We have a private note section. I would document that on the collateral note of some kind or a clinical message. But yeah, I would absolutely document that. And that way you have your documentation. You can say, on this date, I documented it this time. The best case scenario is to do that in private notes. But yes, if you think that note might escalate the risk of self harm, it could worsen their crisis, it could sabotage a safety plan. You could say, them looking at their notes, that'll sabotage the safety plan that we have worked on. Yes, then that would apply. But there's got to be imminent and significant risk, not just emotional discomfort. Absolutely. We'll get a copy of the presentation slide. So I hope that helped a little bit in explaining that to clear some of these things up. I've got some other things that I want to talk about with behavioral health certificate. And if I didn't get to answer your question, just post it again because I'm getting a lot of questions in the private and in the public. And I love questions, so keep them coming. Okay. But these are some behavioral health statistics right here. And I think the main thing that we need to see here is how the data really highlights opportunities and challenges. Like patients can benefit, but a lot of providers don't have really clear guidance. And I think that's where training and templates come in. And I want to be very honest about this. And again, this is my personal opinion. You may have opinions that differ than mine. I love hearing those. I'm very open minded. But when this started, it basically put the onus on the clinician to say, hey, you got to document enough information where you remember what's going on with the client. And you need to document enough information where other clinicians can see your note, but don't document to the point that it's going to hurt the patient's feelings because they're going to see the note. And I don't think that can give always a true clinical picture of how the patient is because you don't want to put manipulative in your note now, right? Because the patient may be very manipulative. Like some of your clients and patients are extremely manipulative. But you have to say something like, I don't know, catchy, like the client is facing intense emotional stress or trauma and has developed creative strategies to get their needs met. I came up with that one on the fly. But that it's a really nice way of just saying manipulative. And you're like, October, what? I write all the content for ICANotes. So I'm used to writing content. ICANotes is a click button system where you click and it produces the notes. But yeah, you have to say things like that now. And I think that can get really, really dicey. Somebody said dicey in the chat, and I love that. Let's see. I let Stuart, so let me get I got a couple different ones here. Rosa, have a good day. No problem. We'll get the slides to you. Carmen, are we allowed to offer therapeutic interpretation support to the client with the notes? Yes, absolutely, Carmen. I think that is an excellent, I think I said that in the beginning, but I also think it's an excellent suggestion. Yes, therapeutic interpretation. I love the way you said that. Absolutely. So, Thaddeus, so psychotherapy notes are, yes, but may disclose clients. Let's talk about that a little bit more. Thaddeus, absolutely. Becky, if it's dual diagnosis, would the Ford still protect Becky? That's also a really good question. Yep. So let's dive into that. I've got this coming up. So that's good. Let's talk about Stuart. Yeah, no, I saw it. Stuart, I want to get Stuart's question answered because he put it in the private and the public. And so that's good. Let's do it. I like generative AI because it can create client-friendly note summaries. And iCannotes is working on generative AI, which is we call it a like listening. We have a really pretty name for it, but basically we have two options of AI that are coming out in Plus. One that will take the note that you created and make it more patient friendly, but also still very clinically sound. And then we have like ambient listening is what we call it. Ambient listening, where it'll listen to your session and then create a transcript from that and create a note. Now I know not everybody wants their sessions to be listened to, and that's fine. So that's why we have the two option where you have the note And that's coming up in plus, and we're really excited about that. Matter of fact, we have people that are beta testing that now. It's highly practical, this generative AI, because I think what happens and why I like AI in a sense is it really bridges the gap between clinical language and client comprehension. And I think it will reduce the risk of misinterpretation by translating jargon. Sometimes you sit down and write a note and it's hard. You know what you want to say, but it's difficult to get it on paper. And also AI can reframe that tone a little bit. I think that AI, some of the tools that are out there now, I know our particular tool is going to support health literacy. And that's just going to build transparency, trust. You're asking about the Cures Act. Not on its own does it satisfy the Cure Act, but it can be a powerful complement to compliance. I hope that that is something that you'll see. But using a fictional note and a friendly summary is going to meet legal requirements. Okay, it is. Absolutely. Absolutely. All right, I'm going to pile through some of my other slides. We've got some great questions out there, and I'm going to be answering those. I'm writing notes for patients to review. I think it's really important you avoid jargon and use trauma informed kind of strength based languages. 74% of patients who read their mental health notes felt more in control of their care, and 61% said they trusted their provider more after accessing the notes. So those are good stats coming out about it. But that's one thing that we just keep it clear and concise, because you don't want your note to be misinterpreted by a vulnerable patient at like 2 a.m. in the morning. So just let the documentation be a part of that healing. Absolutely. We had a question on about psychotherapy notes. So under HIPAA, psychotherapy notes, they are notes that are made during a private counseling session. They're kept separate for the rest of the medical record. They're only really used for the therapist's own reflection or processing. They are not progress notes. So now HIPAA does not really require you to share psychotherapy notes with the clients, and they're explicitly included from like cures. So I think psychotherapy notes can be subpoenaed though. I want to clear that up, that they can be subpoenaed. They do have a higher standard of protection, but especially if you have like the attorney of your state, the state attorney or the FBI coming after you for any kind of fraud, they absolutely grab those notes. So for a patient, you can always challenge a subpoena and you can request a protective order. You can do those things, but many states consider them privileged. So I want to, in the client request, there are exceptions with a psychotherapy note. So subpoena, you could challenge that. But if you include those psychotherapy style reflections or you're doing really deep process work, that's not a regular progress note. A lot of places, like sometimes you can put those in the private notes section and you don't share those. Okay. You don't share those. So I hope that helps answer that question a little bit. I had another question. Let's see. I'm getting a lot of questions and you guys are great. Stephanie says, this is apply to psychiatrists and psychiatric nurse practitioners with their initial follow-up evaluations. It does, Stephanie. It absolutely does. A great question. Shonda says, can we charge for the cost of paper to print the medical records? Oh, I see what you're trying to do there. I see, but no. I'm just tell you, I would tell you no, absolutely. I see what you're getting at. Paper's expensive. I hear it. But no, no. Becky says, if it's still diagnosis along with substance use treatment, would the 42 CFR Part 2 still protect the privacy of the records? That's really good. That, I like that. So the treatment that's being provided in Part 2 is like the provider of the program holds itself out as providing substance use diagnosis, especially if you're receiving federal assistance. And the program's primary function. So there's three little things that let me make sure I get these all right. One is the primary function of the program is to treat substance use disorders, right? That's where, and then you receive federal assistance and then you hold itself out as like providing that. If all three of those things are true, even if they have a mental health dual diagnosis, they are protected in Part 2. But if you're just like a mental health provider and that's not all you do, if you're outpatient therapist and you just incidentally treat substance use, and you're not part of two, and you're not receiving federal funding for that, then that's not two. So the Cures Act doesn't, I want you to know, it doesn't override part two. Part two protected records are not disclosed, even via a patient portal. Part two records, just for you guys to know, they don't even go to the HIEs, the health information exchanges for the state. You do not send information there. So if you're using EMR and you're linked up or to an HIE and ICANotes we have where you can opt out because those don't go to an HIE either. So yeah, I hope that answers that question. There were some nuances to that though. Let's see. Ooh, Ben, really great question. I'm gonna get your question as well. You've got what's my obligation? I love that. And that's very intuitive and a very good question. So I will get to that. Absolutely. Somebody says, I don't feel like I can be fully honest in my notes now that the patients can read them. I hear you. You can and you should be honest, but you got to do it with care, right? Just use this objective kind of behavior-based language. You have to avoid assumptions about motives and you have to consider how your words are going to be received. But yeah, no, I hear you and I absolutely hear you. I definitely think there are problematic in there. So let's talk about that a little bit. I think that these are, and I have a lot to get through in the next 15 minutes, so I'm going to speed up if that's okay. But with this particular slide, I know that some people are feeling like pretty good about open notes, but there was also a study I found that said 1 in 3 patients said they felt judged or confused by the language of their mental health notes. And when the language was reframed, the patient satisfaction scores went up over 20%. So you've got the good and the bad. And that's why research is so important because you collectively get all this data. And I would stop using phrases in the notes like patient claims to be sober for the past week. I would put things like patient reported being sober for the past week because claims that can imply doubt or suspicion. So just be neutral in what you're saying. You could say things like patient expressed concern about, or the client identified goals related to, things like that. I got another question in private. Are we required to rewrite all our templates now? No, I don't think you need to rewrite all your templates. I know with ICANotes, we rewrote a lot of our templates to make changes like that, and we continue to do. Here's some other documentation pitfalls, like the overuse of non-compliance or manipulative resistance. I think we already talked about that. Using diagnostic shorthand. I would not use like SI or HI like that. I know that's a common abbreviation, but they have no idea. A simple one that came up was FU for follow-up. The patient sees that like FU and they think that, I mean, it's ridiculous, but you just got to be really careful. Also, I think from this slide, I'm just going to focus on including third party references without consent. I know that you can get collateral information. Like you can't call a family to ask questions or talk about the patient, but if they call you, that's a little bit different. But I would be careful putting those in your note on what the family member said, because that can violate trust and privacy. So just ask yourself, like, does that need to be here? Is it documented appropriately? Things like that. I think writing, you can do it clinically accurate, but also be compassionate about it, knowing that your folks know. I got a quick one. Can we still use terms like non-compliant if it's medically accurate? Yes. You can use it, but I would be careful with it in its context. Like I would talk about like why they didn't follow the recommendation. Was it the cost? Was it the side effects? Was it cultural concerns? Like why were they non-compliant? And so that turned a really kind of judgy term into clinically useful, right? So absolutely. Spicy question. I love it. If a patient is being clearly manipulative, are we just sugarcoating the truth and not calling that out in the note? I love your spunk. It is not about sugarcoating, though. It is about precision and professionalism. Manipulative is a really loaded word, right? It it describes a lot of behavior, but I would document the observable behavior, right? Client was making statements when discussing, I don't know, their discharge planning and appeared to seek a specific outcome. I would say something like that, right? It's honest, it's objectable, it's defensible, things like that. Absolutely. All right, let me roll through some of these slides. I'm going to get to the questions for sure. I've been trying to answer some of the easy ones. I'm going to get into some of the harder ones. Tools for compliance. Oh, I already did this one. So this was like earlier in the set here. Tools for compliance, using a checklist. I think that this is really important. There was an audit that ONC did in 2024, and they found that 72% of organizations that were cited for information blocking lacked formal documentation protocols or staff training. And you're in a training today. So you're doing really good. You're ahead of the pack. But organizations that used checklists and audit trails, they had 40% fewer compliance issues. That's why we gave you a checklist as a handout today. So I want to really shift I want to shift off the narrative, like what not to do and what you can do to stay compliant. So use the checklist. That helps make sure you're meeting exact criteria. Use audit trails. Those are your insurance policy. Okay. They reached out to me for the notes. I did this. And don't assume that everybody knows the rules just because they're a clinician, because there are so many rules and laws and regulations coming at you from a federal basis, from a state basis, that it's almost impossible for me as the compliance person for an EMR to keep track of it all, much less you when you're trying to just manage your patients, do your day to day, get your billing out, do all those things. So I think that's really important. You can give your patients education on this if you want, but Ben had a question. What obligation do I have to inform my patient? You are not legally required to notify each patient individually at all. All right. That is the law. That's it. Legally, no. Now, strategically and ethically, maybe you can tell them you can have access to your notes, but you're not required to. You're absolutely not required to. The Cures mandate is about access. It is not about notification. So if the patients, if they don't know their notes were available and they could have had them, they might be a little bit surprised or confused. But it's about access. It's not about you notifying them. So yeah. I hope that answered that question. No, you don't have legally. No, absolutely not. All right. Let's see. I'm going to keep it rolling here just on a few of those slides because I still have 6 slides and we are running out of time. And I want to show you how it works in the system. And I want to get these questions. So this one is common behavioral health scenarios. I will just tell you that over 60% of clinicians reported concerns about patient access to notes. That was the year after the first study have done this. But it's so again, if you're concerned, I get it. You could still document suicidal thoughts. You just do it clearly, compassionately, especially if you believe releasing the note would escalate the risk. Group therapy notes. This is a question, and I got it in my private chat. The Cures Act does not require you to share notes that contain other patients' protected health information. So you can use group notes internally, but they should not be released via the patient portal unless they're individualized notes. Anything with high conflict custody cases, be really careful here. You got to be careful because a lot of times these folks will come subpoena stuff. So you got to be precise. You got to be neutral. You got to avoid emotionally charged or subjective descriptions. If one parent requests access, there's this legal ambiguity about guardianship. You got to check all those legal statuses. So these scenarios, though, are not reasonable to avoid documentation, but you just got to do a lot more thoughtfully. Okay. You just ask, can I skip documenting suicidal ideation altogether if I'm worried about the patient and they will react badly? No, skipping is going to be a liability. You should always document risk for suicide. I would always document what their safety is, how we're continuing their care, and get a safety plan on the chart. If I can preach about anything and protecting yourself, because I'm really big on clinicians protecting themselves. I work for a law firm who protected clinicians, and we've not let patients come soon. We protected large organizations. Get a safety plan on the chart. Sorry, get a safety plan on the chart and ask them if they're suicidal every single time you see them. I did a webinar not too long ago on like how to protect yourself from liability, and that is the nutshell of it. All right. We'll just put this here. I will say that Cures doesn't really change how we share information. It just changes our legal and ethical responsibilities. I've already went into HIPAA, so I want to talk about that. I got a question about, would a trauma narrative be separate? Any quotes? And what about cases reporting to CPS? Would a trauma narrative be considered like a psychotherapy note and kept separate? Yes. If used appropriately. Yes. I think it's, especially if it's used as a part of processing work. Absolutely. You can keep it separate from the clinical. What about direct quotes? I like quotes. Look, quotes can be very powerful. They tell a story. And especially when you get in court, you want to tell a story, right? Especially if your patient commits suicide and the family is suing and the patient sat there and said, my family doesn't help me. And they don't care anything about me. And now you get into court and the family's suing you. That actually looks that you're much more protected that way. I like quotes. I'm sorry. I like quotes. Use them. use them. They said it. It was their verbatim words, use it. So absolutely, I would do that. All right. As far as CPS reports, I wouldn't necessarily put a trauma narrative into a CPS report unless it's directly relevant. All right. I want to say that. I haven't, yeah. So I want to say that. Let's see. If I utilize an EMR, do I need to make all records covered by the CARES Act shareable on my portal? Can only share what the client requests and make the request. Okay, Monique, that's a really good question. And ICANotes, we have the patients go into the portal, they request their records, and then you can share them. And we're going to show a little demonstration of that. But there's a box you can click because you're not going to remember if that note is like you did psychotherapy in that note, right? Or maybe that's a legal note or something, or it could be a note that could cause harm. We have a box that you can check after each note that says, don't share this note. And then you can go and review it. It's also helpful for large practices when maybe the front office person is the one sharing notes with the patient gets requests. But within our system, the patient must request them. They haven't come down and said, that's not right. Yeah. So that's what we're doing until we're told otherwise. But no, we don't automatically push it to the note because we're behavioral health EMR. Psychotherapy versus progress notes. I think that psychotherapy notes are for the therapist. Okay. It's like psychotherapy notes, they're analyzing the content of the conversation during a private session. Progress notes are for the clinical summary of treatment for the official medical record. Psychotherapy notes can be kept separate from the client's medical record. All right, they should, but that's not what a progress note is, right? Psychotherapy notes are protected from disclosure. Okay. And then, so progress notes are not. Okay. You can't use necessarily a psychotherapy note for billing, right? But yet you use a progress note because that's got your documentation in it. You send it out for claims, they can audit that, all of that. So, yeah, I hope that kind of helps. Like a psychotherapy note would be like, let's give an example. Client explored vivid imagery of a drowning dream tied to unresolved grief, intense emotional expression, and therapist noted strong countertransference related to the client's helplessness. A progress note would say something like client discussed past trauma experiences, process initiated, emotional distress noted, safety plan review, no suicidal ideation reported. Boom. Does that help the difference between a psychotherapy note and a progress note? I hope it does. Let's see. A lot of great questions here. I am going to, can we charge for records for third party requests? Yes, you can. If it's a yes, there can be third party requests, but not for the clients. Great. Edwin, I like what you're thinking. So very good. All right. I hope that answered. Are there, let's see. Got use the client's old words. Love it. Yep. What about notes that are outside of the session, like emails, phone calls, and text? Really good question. Really good question. We're 1 minute to. I'm going to have Larry show you on ICANotes how that works. So, Larry, if you want to go ahead and start sharing your screen, you want to get that pulled up so we can run through that really quickly. Super easy way that this works. You can remove my slides here. And then let's see. Is there a boundary where therapeutic support for notes may be considered withholding or problematic? Yeah, that's a very insightful question. Yes. So what I'll say really quickly is it can drift into non-compliance with the Cures Act and information blocking rule if you're like delaying, you're filtering them, you're conditioning access to them. But providing therapeutic support around notes is encouraged. Okay. Cause that may save you a lawsuit, to be real honest with you. I'm sorry. I keep it real in these because I don't sugarcoat things very well. So, yes, it'll help with the trust. That can always avoid a lawsuit. But you wouldn't want to be like, I will release it after we talk about this the next session. No. You'll be like, let's go through this and we're gonna talk about this more in depth and things like that. So get them to work with you on that. Let's see. All right. Thank you so much. Thank you. Thank you. Thank you. All right. No, thank you guys. You guys are great. Absolutely. Yes. Somebody says, sound like I can specifically as a compartment section for private notes. Jonathan. Yes, Jonathan, we do. What if I want to keep some private notes on a Word document? Is that considered therapy notes? Coming at me with the hard questions. You better be glad I like you so much, Jonathan. If this is the Jonathan I know. So I will answer that for you for sure. I'm gonna have Larry show this and then I will absolutely answer that question for you. Great question. Are you the Jonathan I know, like personally know? I think it's not, you have the exact same name and that would be phenomenal. All right. Larry, go for it. I'll hush for a
All
second.
right.
I'm sorry as we're over.
Okay. Can you hear me okay?
Yes, I hear you great.
All right. Excellent. Okay. So one of the questions I saw that was coming up was how do you give access to the client portal or give that access to the patient? So I wanted to start with that. So when we do go into a patient's chart, one of the options that you have, and I'm showing you first from our classic system, and then I'll show you from the plus system as well. But when we select a patient here and we go into their chart, under the demographics, do want to have make sure that they have an email address. And then we have a little portal box right over here. And when we check that portal box, and we do have an email address in the system, that will send the invitation to the patient so that they can register for the portal. And they'll put in some basic information, name, date of birth, I think, and then they'll create a password. Okay. Or I'm sorry, in Classic, they'll create a username and a password. Okay. So that's how they can gain access to it. Now, once they have that access, okay, then when they go into the patient portal, what we do have available for them is this request record button. It's up here in the upper right corner. You can kind of see that. They'll click on that request record. They'll select whoever you have designated to receive these requests. So you can see it, they select the name. The information is written out here for them, the request, but they can even add in specifics if they wanted to put in a specific date range, a specific date, things like that. They can add that too. But then they would hit this send button. Okay. And on our end, the receiving end, your end, what they're going to be able to see, or what you guys are going to be able to see, is on your chart room, you're going to have a little notification button here that says you have some unread requested records. So you'll be able to select or click on that. It does open to your internal messaging system, but these messages are coming from the patient portal. So we do want to click on the patient option. And so I can see John Smith has requested some records. Okay. And if I click on the little R here, of course, if I click on the message, I can see the message that they sent. But clicking on the little R here, the capital R, is going to open up into all of his, where I can see all of his records, all of his notes, and I can select which ones I'm going to send them. Okay. Or I'm sorry, it's going to include those. I can select which ones that I want to omit. All right. We can add some comments in here. We can show them the notes. So here I can click this upload records and allow access once I've gone through my list. And again, if there's some that I need to omit, and then when I click, that will make those records available to the patient through their portal, and they'll be able to log into the portal and be able to see that information. Once I've done that, I can come back here and I can see the little check mark to know that I've fulfilled that request. Okay. And again, those would show back up under the My Records here for that patient to be able to view that information. Okay. The other option that you do have is if you go back to your login screen at ICANotes, under the upload to ICANotes, and I'm sorry, let me go back one more step here. Whenever you do create your records in the system, okay, into your patient's chart, they all are logged or documented. Their copy of those are held under this Documents tab. Sorry, right here. Okay. So you'll be able to see all of those notes, all of those documents here. Now, where that also shows up is, again, from our login screen, if we go into our upload site, that those same folders, that same information that's in that Documents tab is listed here. Okay. So if you are uploading anything into the system, let's say you do have your notes on paper or you do have them in a Word document or anything like that, when you upload that information into the system, there is this option here that you can just check the box that the patient can view that medical record, that information. So that's an option too, if it is something that you're uploading into their chart that you want to make sure the patient can see as well. And then again, that's from our classic system. Now in the ICANotes Plus, which is logged me out, but our newer system, again, starting with giving patient access to the portal. If I go into a patient's chart and we go to the communications tab, we have our client portal option here. And I'm just going to click on this activate client portal access. If I have already entered that patient's email, it will let me select their email from the drop down here. Let me go ahead and I can select that email address, or I could add it here as well if I haven't already put it in. But that'll do the same thing. It'll send that invitation to the patient. They can register for the portal. Their login would be their email address and then a password that they create. Okay. But we don't yet have a button like we do on the classic portal where the patient can just click that request record, but they can send a message. Okay. They can send a message, and those messages are going to show up here under this messaging drawer. We will also get a notification with the little bell icon here in the corner that will say you've received a new message from this patient. And then we can click on that message and it will take us to this messaging area. But to share those documents, like I said, in Classic, whenever we create a note, we get a copy or they all show up here under the Documents tab. Okay. Same with our same with the Plus program. But here, I can go through and I can find those notes that they're requesting. Okay. Whatever it is, maybe not the lab order. But I can find those notes. I can select those, or again, this may not be a popular option, but if I did need to select everything, we do have the select all option here. And then once I've selected what I want to share with that patient, then I can just click on the share option. And again, that would then make those notes, that information available to the patient through their portal.
Thank you so much, Larry. I asked
Sure.
Larry about 30 minutes before this to jump in and show this. So, and he is like amazing. So thank
No
you.
pressure.
Thank you. Yeah, none at
Thank you.
all. You did fantastic. I want to thank everybody that came today. I have a couple other questions. Listen, I am on LinkedIn. Feel free to reach out to me on LinkedIn. I'm also with ICANotes. My email is october@icanotes.com. We do offer consulting with ICANotes. We just opened that up like last week because people have asked for it so much. We don't even have our prices established. That's how new it is though. So if that's something that you need, we definitely now provide that with ICANotes. It's just brand new. I did get another question about records. What about somebody that requested a records that are 10 years old? If your state only requires 7 years, then it's been 10 years. You're likely no longer obligated to provide those records. Unless it's a kid, okay? Unless it's a kid. If you still have the records, then that's great. You can release them if you want to, but I would get in your office a clear retention and destruction policy. Now with children, it's a lot higher. It's a lot higher with kids, but for adults, a lot of states say only 7 years. Some are gonna be moving to 10 though. So I so appreciate everyone that was in here today. Y'all had amazing questions. If you didn't get to them, or if I didn't get to them, I'm so sorry. You feel free. I will stay on. You can continue to post questions. I will continue to answer them. But I just appreciate you taking the time to be here today and to learn about the Cures Act. I hope this information was helpful. And it is a little concerning. I had some clinicians saying, look, this is scary. I hear you. Absolutely. But I hope we gave you a little bit of direction in which way to head to handle this. So, again, really appreciate you being here today. All right. I hope everyone has a fantastic day.